In this section, we will discuss important anatomic features of the adductor canal block. More information about the saphenous nerve above the knee has been presented in an additional lecture. As with any nerve block, a correct understanding of anatomy is the best way to achieve a safe and effective result. As we have previously mentioned, in these lectures we will demonstrate some examples of how to perform these blocks. However, our hope is that by presenting the anatomic basis for these blocks, our techniques as well as the techniques of others will be safer and more effective. In November of 2009, we published a brief review of the anatomy of the adductor canal. At that time, we also reported the first successful use of the adductor canal block as a motor-sparing alternative to more proximal blocks at the level of the inguinal ligament. Since this publication, there has been considerable interest in this technique as a means of providing motor-sparing analgesia after knee surgery. Prior to 2009, the adductor canal block was recognized as a method to produce proximal saphenous nerve block. In our 2009 report, we detailed a number of other nerves present in this compartment that explain why the sensory changes associated with this block are much more extensive than only that of the saphenous nerve. These include the medial femoral cutaneous nerve, articular branches of the obturator nerve, the medial retinacular nerve, as well as anterior and posterior divisions of the femoral nerve. This slide shows an outline of the extensive sensory distributions on the medial and lateral aspects of the lower extremity that are affected by local anesthetic injection at the level of the adductor canal. Next, we will see a detailed anatomic dissection of the adductor canal. In this dissection of the medial aspect of the left thigh, the skin and subcutaneous tissue have been removed. In addition, the gracilis muscle has been detached proximally and reflected medially. Remaining are the sartorius, vastus medialis, adductor brevis, longus, and magnus, and the semimembranosus, semitendinosus muscles. In this image, the gracilis and sartorius have both been detached and reflected medially. With the sartorius reflected, the superficial surface of the adductor canal is visible. After incising the fascia between the vastus medialis and the adductor muscles, the femoral artery is visible within the adductor canal, as well as the saphenous nerve. The saphenous nerve is the terminal branch of the femoral nerve. Note how the saphenous nerve leaves the adductor canal by passing superficial to the tendinous insertion of the adductor muscles. The tendinous insertion of the adductor muscles can be mistakenly identified as the saphenous nerve on ultrasound. After crossing this tendon, the saphenous nerve travels between the sartorius, which is reflected in this view, and the vastus medialis muscles before passing deep to the pes anserinus. The pes anserinus is a confluence of tendons from the gracilis, sartorius, and semitendinosus muscles that attach to the medial aspect of the proximal tibia. In this medial view of the left thigh, the adductor muscles are being retracted anteriorly and separated from the semimembranosus, semitendinosus muscles to display the deep surface of the adductor muscles. The femoral artery can be seen passing through the adductor hiatus into the popliteal space where it becomes the popliteal artery. This adductor hiatus, or opening in the adductor muscle, defines the distal limit of the adductor canal. Note that the femoral artery passes through the adductor hiatus at about the same level as the saphenous nerve passes superficial to the adductor tendons. This dissection illustrates with suture ties the multiple nerves present in the adductor canal. These nerves include, but are not limited to, the medial femoral cutaneous nerve, the articular branches of the obturator nerve, medial retinacular nerve, and branches from the anterior and posterior divisions of the femoral nerve. This is why local anesthetic injected into the adductor canal produces sensory changes, which are much more extensive than just the distribution of the saphenous nerve. Note the position of the saphenous nerve as it passes superficial to the adductor tendon. The blue arrow marks the point at which the saphenous nerve is no longer within the adductor canal. Thus, injections performed proximal to this point are anatomically within the adductor canal, while injections performed distal to this point are in anatomic plane between the vastus medialis and sartorius muscles. These simultaneously recorded videos of the ultrasound image and transducer position demonstrate a systematic method which can be used to image the adductor canal. Starting at the level of the superior pole of the patella over the vastus medialis, the transducer is moved medially and posteriorly. The first tissue plane encountered is that between the vastus medialis and sartorius muscles. In this image, we find the tissue plane between the vastus medialis and sartorius muscles and then move the transducer proximally while maintaining this plane between the sartorius and the vastus medialis in the center of the screen. As the transducer is moved proximally, the femoral artery and vein are visible within the adductor canal. Note how the vein can be recognized since it is easily compressible. Remember, an important distinction between the femoral artery and vein at the level of the inguinal ligament and the femoral artery and vein at the level of the adductor canal is that the femoral vessels and femoral nerve are in separate fascial planes at the level of the inguinal ligament, but the vessels and nerves are within the same plane at the level of the adductor canal. Thus, extreme caution should be used to avoid intravascular injection within the adductor canal. This is another example of a methodical way to image the adductor canal. We start by placing the transducer over the vastus medialis at the level of the superior pole of the patella. As we move the transducer posteriorly and medially, there is an obvious tissue plane, which is the plane between the vastus medialis and the sartorius. This tissue plane contains the saphenous nerve, which is rarely visible on ultrasound. If we move the transducer proximally while keeping the plane of the sartorius and vastus medialis in the center of the screen, the femoral artery and femoral vein will become visible. At the level of the adductor canal, the vastus medialis, the sartorius, and the adductor muscles are all visible, as are the femoral artery and femoral vein. Neural elements are also commonly visible at this level within the adductor canal. This diagram illustrates the relative positions of the sartorius, vastus medialis, adductor muscles, femoral artery, and femoral vein. As we mentioned earlier, the adductor canal block varies from the femoral nerve block at the level of the inguinal ligament in that the femoral artery and neural elements are in the same fascial compartment. This is unlike blocks at the level of the inguinal region where the artery and nerve are separated by the fascia iliaca. Thus, the adductor canal block is analogous to the axillary brachial plexus block in the sense that both blocks are defined by distribution of local anesthetic around the artery. Also, since firm pressure on the transducer may compress the femoral vein, caution must be used during injection. In this example, an out-of-plane injection is performed at the level of the adductor canal. Note the needle advancing through the sartorius muscle. Injection adjacent to the superficial surface of the femoral artery results in extensive distribution of local anesthetic throughout the adductor canal. Thank you.